We may go just a little over the hour, gentlemen, and lady, 9:15-ish or so. We can cut it off a little before then. So I think we should try to get through the cases and keep it nice and concise so we get through all the cases. Billy?
Right, so this is mine. This is a 53-year-old female patient who had a previous decompression by a very famous harm study group surgeon who moved to Syracuse, Tom Hare. So Tom did a Lamy on her and then retired. And unfortunately, she developed a iatrogenic spondylolysis with listhesis. She's a little bit on the heavier side. She's got a BMI greater than 40. She failed conservative care. But this is her imaging studies. You can see on her x-ray. She's a little flat at 5'1" and 4'5", part of her degenerative process. The Lamy at 3'4". She's got, again, the disc height loss and a listhesis. You can see on the CT scan the cleft through the pars and articularis. And there's MRI images that show some lateresis, but more foraminal stenosis.
And bone density is okay on her, Billy?
By Hounsfield's unit, she's over 130.
Okay, great. So central canal here.
Right. So again, primary lateral recess and foraminal stenosis is what she has.
Yeah.
So. And so what we see is her intraoperative images. So her intraoperative images demonstrate I localized on her skin. I made a standard, lateral approach. Split her external abdominal muscles, got on top of her psoas, retracted her psoas, and there was a little video that showed serial dilators to try to dilate her up, and then placed her standalone lateral device, deployed her staple very nicely. I guess the interesting thing is that she had a little bit of a lateral listhesis, and utilizing the combination of the staple and the plate, I was actually able to reduce her lateral listhesis as well as her annular listhesis. So she was a bit of what we would call an allostatic patient. So the device helped out with that too. Next slide.
Yeah, that's kind of, I think that's it.
Thoughts of using a dual double 2 screws above and below? Or did you feel you had good fixation with this?
Well, I thought her fixation was good, but that was also the implant they had. So.
I see. And you were, she has good bone density, and this is a great standalone option. And yep. I don't know if you have any follow-up on her.
She's just recently done. She's done about a month ago, and she seems to be doing well. So
beautiful. Great case. Ed?
This I did today. This is a 54-year-old male. He had a prior 4-to-1 Lamy fusion, standard adjacent segment disease at L3-4 with moderate to severe canal stenosis, back pain, claudicating pain in the legs. He had failed all conservative options, so we went with standalone lateral. Pre-op imaging, just a pre-op CT. So I sent, just for you, Randy, I saved like every fluoro shot pretty much. So, I dock in the anterior third, dock a retractor, stand on the belly. I pass a spreader about halfway through, and then I just confirm where I am, A to P. And then I can continue on. Then we serially dilate, do the discectomy, and then pass the implant. You can go to the next slide. And there's the implant getting seated, staple deployed, screws. Final construct.
Beautiful. Right just above the pedicle screw there.
I love this. Love this for revision adjacent segment. It's a great operation.
What do you use for graft, Ed? BMP, something else?
I kind of got away from BMP because I think iFactor does a really good job. So does some of the synthetics, like Magnetos, like these ceramic matrix products. They make a lot of bone. Like there have been a couple of cases where I'd used them actually in the posterolateral lumbar spine. I'll have to go back in, a year and a half or 2.5 years for something. And I'm impressed by how much bone has been made. Like they really seem to work. So I kind of got away from Infuse just because of the risk profile. I know it's been used forever, but these like some of these newer products, I think, are just safe.
Any thoughts about a double 2 screws above and below? Just didn't think you needed it.
So I didn't think I needed it for this. You know, I do think back to Billy's case, when there's like true 3-column instability, I would be inclined to consider it.
Yeah. Okay, let's go to the next one. Rapid fire.
So I
Okay.
would be concerned to put just 1 screw above a previous solid fusion, because I think there's a huge lever arm on there. I just wanted to say that. So might be something that we can biomechanically test in the future.
Thanks, Evelina.
So, Evelina, what do you think? You'd rather a 4-hole plate there?
Yeah, I'm just worried about you're actually fracturing a vertebrae, putting in a cage, putting in a plate with a single screw, and you have a big lever arm below it because you have a solid fusion below it. So I would worry about this patient with just 1 screw fixation.
I think more options would be ideal.
Yeah.
I agree.
There is a 4-hole plate, so that's available, and that can be
I
used.
will just comment on that quickly. So my standard of care for a lot of these cases used to be standalone interbody with a 4-hole lateral plate that was not associated with the implant. So I don't know if that makes a difference, having the plate attached to the implant. But my finding on the 4-hole plate was that you would consume quite a bit of bone just right there in that subcortical region, and I would see cleavage fractures through usually, in this case, the superior vertebral body. So in this case, it would be the bottom of L3. We'd see fractures through that, which actually unintentionally makes your intervertebral osteotomy at that level where you were hoping to stabilize it. So I actually went to 2-hole plates and had much better success as far as fewer fractures. And in this case, I think we always have to ask, what are we trying to prevent? And we're trying to really prevent, I think, anteriorization or lateralization of that plate. And with the staple on the far side, that's going to prevent lateralization. And I think the combination of the staple and even a single screw going up and a single screw going down will prevent the anteriorization or posteriorization of that interbody device. So I've got more experience with a dissociated plate, not part of the implant, but I'm eager to try just the 1 up, 1 down because of the issues that I've had clinically with the 4-hole plate.
Good points, Roland. And Evelina, we'll have to do some biomechanical tests as time goes, for sure. Testing.
Yeah.
Let's do Sherby.
Sure. So I've got a couple of cases that I think we all see pretty routinely in the office. It's a 58-year-old male. He's got some component of back pain and leg pain, little hypertension and GERD. He's done the standard stuff, PT, epidurals, meds. It's not really resolving, not getting better. He has both back and leg pain, but he has more leg pain than that. When I look at this guy being 58, there's no dramatic spondy or anything to scream at it and say that it's something that I'm inclined to think about a fusion. I would love for this case to be a 1-level spondy, which would be great, which is not what he has. Rather, he's got this kind of multi-level degenerative looking spine, and the central canal really looks really pretty good. There's plenty of space here. So it's a tougher one as to what to offer this guy when he's really not getting better. But if we peel off to the left and the right, in the foramen here on the right side, he's really, on the left side, he's really got this foramen that looks really pretty small. He responds to the pain guy's transforaminal injection. So this seems to be an option that, maybe this is the right kind of patient for this, right? But nobody has no back pain, right? Like all of us probably have some back pain. Certainly I do. But I mean, this guy's looking for something. We're trying to make it better. So I think this is the kind of patient that I'm thinking upon for a VBO, and kind of this kind of dark orange foramen is what I see. We try to pull it open. One of my partners talks about how, okay, this is a continuum of process. They're not symptomatic until the very end. the proverbial last millimeter that went, that now is their foramen is too small, and now they're really pretty miserable. So maybe, we don't like that CT scan gave it 5 millimeters. Maybe we don't need 5 millimeters. Maybe we just need just a little bit, right? And that's kind of what I'm inclined to think here.
What about the devil's advocate? Some will say, why don't you just do a foraminotomy? Why do you need a VBO?
Yeah, I mean, it's a great point. I throw my kerosene way out there, and I think I do a great job with my decompression. And then plenty of times, they're still symptomatic from that. And you get a scan and the radiologist is still terrible stenosis. You suck. You don't know what you're doing. And so maybe this is something that I would do a TLIF on, but I don't want to fuse them, right?
Right. So it's a case you might do a TLIF on. If there's vertical up-down stenosis, you may not be able to decompress that with a kerosene. That's the case you're thinking about for this, right?
That's exactly kind of what I'm thinking there. I'm not confident that I'm going to get a good foraminal decompression. I might do an MIS TLIF and be pretty happy with my foramen, but then I've gone on and done a fusion, maybe when I don't want to, on this, or maybe the patient doesn't want one either.
Often the patients don't want one. And they hear a lot about, spinal fusion. Those are the patients that come to me in my office, and I hear such horror stories about spinal. So I think a lot of it will be driven by patients as well. But of course, we're going to have to be careful in our selection,
right,
and our indications.
So exactly to that point, I am looking for the right case. And here's another one, another 55-year-old kind of a thing, a little hypertension, hypercholesterolemia, doing the standard things, more degenerative over. He has more leg pain than back pain. He has some claudication kind of symptoms. So he's got bilateral symptoms. It's not just one level, but it's again, like all the way up and down. And, is this the kind of patient? Maybe really, can you do something here and open up the foramens throughout, rather than ending up doing a multi-level laminectomy, that kind of thing. And so I think these are kind of patients that we all see, and are sometimes like, gosh, I don't know. Does he need a lot? Does he need a little? How can we do this? Here would be the cut right below the pedicle. I think it would pop open in this area where things are small, and might give him the case. Again, I'm just thinking about these just like everyone else right now, of how to do it. But these are the kinds of things I'm thinking about.
Excellent.
Well, I'll throw this one out, which is the one I always come up with on these meetings, which is fractionating surgery. Is this something that you could do? And, your most symptomatic level, can you try to shoot for some lordosis, some decompression, and see how they do? And maybe if they don't, come back.
Yeah.
Managing the spine. We're not fixing, we never solve a problem anyway. If you fuse it, you just set them up for the next level. So that's how I talk to my patients. I think it's a good concept, Billy. Who's got another one? Roland.
All right, these are mine, and these are not dissimilar to the ones that are already shown. And again, this is where I see the inner body really being a workhorse for me, is trying to return to standalone lateral. Like I said, there was a part in my career where I was doing these quite a bit and was dissatisfied with the 4-hole plate. And so these are the types of patients that I really want to get back to. And I'm also looking for that perfect intervertebral osteotomy in Shervy. I think that first case was, I was salivating at that one a little bit, right? I think that's a great one to look at and say, hey, this is good. But so 63-year-old female, prior L4 to S1 fusion, mostly pain and now in L3 nerve root distribution. So some degree of nerve foraminal stenosis, maybe a little bit of a coronal malalignment at the L3-4 segment above her prior fusion. Quadriceps weakness, mild tibialis anterior, so a little bit of L4 nerve root involvement, which maybe that in and of itself, argues going to the disc space rather than a vertebral body osteotomy. Normal hip flexion strength, so no involvement of the psoas, no real L2 involvement, and then responded transiently to bilateral L3-4 transforaminal epidural steroid injection. And again, in this picture, you can see that she does have some narrowing centrally, less so really in the neural frame. We can hit play there, and it should go through the MRI, so you can see the axials and etc. So fairly narrow there at L3-4 centrally, which I think argues again trying to restore that disc space height. And then neural framing again tight, but not severely tight. So this is primarily an L3 and an L4 nerve root problem. And, my plan for her from a surgical perspective, given her failure of conservative treatment, would be extension of the fusion up to the L3-4 segment. This is just to demonstrate that she looks to be fused at L4-5 and L5-S1, so I'm not sure that I need to do anything down at those levels. Hardware obviously still in place posteriorly at L4 and L5, which is another reason that it makes it sort of a dream operation for a standalone adjacent segment, is you don't have to mess with that posterior hardware.
Excellent.
Any thoughts from the crowd?
You haven't done this one yet.
This was, this one was done last Thursday. And unfortunately, like I say, I had this scheduled with absolutely everyone before I went and did my lab. I'm excited that I've got some coming up that I'm hoping we'll get in the books for this particular approach. But what I ended up doing was lateral lumbar interbody fusion in a lateral position, and then put her in the prone position and revise the posterior hardware. And
So
this one's interesting because
you went up one level with the posterior implants?
Yeah, just up to L3, removed and replaced, stuffed at L4 and L5. It was unnamed hardware. We actually couldn't find anything on it, but thankfully everything was a T25 for the set screw and a T20 for the shank. So
we
it was
go
the
back
universal
to
screw remover.
Yeah, thank you. Could we go back to the lateral, just the pre-op lateral for a second? Okay, so Randy, are there longer plates that might, because there's not much room if you wanted to do just a standalone here. Is there a plate that's maybe a little longer that could extend down to come under this pedicle screw, or this might just be one screw in the vertebra above if you wanted to do that?
Good question, Baron. Right now, we just have the one length plates, but you can have up to 20 degrees of angulation any one direction. There's a good chance you could probably angle it by the pedicle screw.
Yeah, I bet if you had a true lateral X-ray, I bet you can sneak one in. I've found it. There's almost always some way to sneak a screw in above that pedicle screw beneath you.
Yeah.
Almost. Having done a lot of Canada in the day, it's amazing to me how you can get a screw past that.
Yeah,
almost routinely. It's crazy.
I used the new of a decade plate back when I was doing a lot of these and could always get past it. And keep in mind, that's not associated with the implant. So you can change the length of the plate if you needed to. But I almost always, in every occasion, used the shortest plate, and I was able to get 2 screws. It made me feel better when I could get 2 screws under that near pedicle screw. Better than metal on bone is metal on metal as far as fixation is concerned. And but maybe that's what led to some of those fractures in the superior vertebral body. So in this case, the L3 vertebral body. So who knows? But I would feel actually pretty comfortable that I could get around that pedicle screw, even with whatever size plate we have available.
Great. Let's go to the next.
This one's not too dissimilar. However, she has retrolisthesis, so maybe a bit of dynamic issue causing her neuroforaminal stenosis. Main difference is that this patient is fused from L3 to S1 and has more of L2 and L3 clinical presentation with both hip flexion and knee extension weakness, with everything intact distally. So again, a problem at L2, 3, mostly confined to the neural foramen. This is one that, again, I don't salivate at it quite as much as a vertebral osteotomy because I do think that there's a dynamic component contributing to a retrolisthesis, as you can see on the CT myelogram, where there's less of it. But she has a rotational deformity, which is causing more neuroforaminal stenosis on the right than on the left. And if you hit the play on this, it'll go through the slices, but really no central stenosis. So that's one of the reasons that I'm like, you know, what would it be okay? And I would be a little bit nervous with instability through the disc segment, but I think is perhaps at least closer to what I'd be looking for the intervertebral osteotomy. But again, my plan with this patient would be extension of the fusion up. This is a pending patient, and so yeah, this is one that I definitely have in mind for extending the fusion up. I don't know what anyone else's thoughts are in regards to this, you know, kind of retrolisthesis, rotational malalignment of that proximal segment, that L2-3 segment, whether you'd feel comfortable not instrumenting across that. Meaning I'd feel fine doing a standalone next to it, but taking motion away from that segment, I'm not sure how I feel doing an intervertebral osteotomy when there's a long lever arm down below it.
And you've already got some instability. I would tend to
Right.
agree with you, Roland. I would tend to fuse that one. Any other takers on VBO for this, or no? Probably consensus to fuse that for the reasons you mentioned. Would agree.
Yeah.
We've got another, Michael.
Yeah. Hey, I just had a couple cases here that kind of span the spectrum, I think, of what I'm thinking about as I'm considering who would be best for the VBO procedure, the vertebral body osteotomy procedure. As a patient, just kind of a straightforward one, 66-year-old guy with bilateral L4 radiculopathy, no significant deformity there. Next slide there. He's got a pacemaker, so here's a myelogram. No significant central stenosis, no major sagittal plane issues. Really, it's just bilateral foraminal stenosis, vertical stenosis. You know, I think in most practices this would be a decompression alone. You know, foraminotomies. He's got some back pain, so versus TLIF versus lateral with indirect decompression. You know, there are a lot of different options for this. I ultimately did a TLIF on this guy, but as we think about who would be kind of the best early patients for the vertebral body osteotomy procedure, I think Dr. Sethi has said in the past, you know, somebody without any psychological pathologies with relatively straightforward anatomy, and true vertical stenosis, you know, nothing too severe in terms of deformity to take on. So I have not done a vertebral body osteotomy, but I'm actively looking for patients who would be good for that. So I was hoping to just kind of present this one to the group as a relatively common and straightforward case that I suspect anybody with a spine practice kind of regularly sees, to see what people think about this procedure versus the things that we commonly do, you know, decompression alone, MIS TLIF, open TLIF, lateral.
Good, fair, all good points.
Yeah.
Any other comments, Ed?
Mike, it's a great case because it's like everybody will Monday morning quarterback it. Let's say you did do a VBO on this patient and his radiculopathy went away. I think the question then that I'd ask on Monday morning is, okay, well, does his back still hurt? Is there going to come a day when you say, well, he's still complaining, maybe it's that 4-5 disc, you know, should I have just done a fusion, or am I going to go back in and have to do a fusion because he's got facet arthropathy or something? Right. And that's I think the challenge. We're all saying we're looking for this patient, and the question I always ask is like, well, but am I going to have to go back in, and am I going to regret missing some component of their diagnosis by not doing a fusion, and then I'll never get closure, like clinical closure on the patient? You know, I think that's
you're absolutely right. I think it was a recent meeting where Randy said something along the lines of, you know, more and more we're going to have patients requesting motion sparing options, less and less requesting fusion. And so your thought process, Ed, is exactly what walks me into this TLIF. But I, I'm sure we all do see plenty of this case where the person says, I want to avoid a fusion at all costs, in which case you now kind of have this expectation and rapport established with the patient.
Mhm.
And maybe that's the best first patient, or first few patients is something straightforward, really wants to avoid fusion, really likes the idea of motion sparing, and is okay with the possibility that if this doesn't work, we're going to end up doing the TLIF or whatever your standard is in terms of decompression and fusion.
Yeah, that probably makes sense. I mean, I'm sure Randy and Baron can attest to this. I mean, when I started tethering in Syracuse, the people who I started tethering were people who were looking to be tethered. There weren't people I was telling to have a tether. They somehow like found me in outer space and were like, "Hey, could you do this?"
Tether.
And I could tell you, I was a Modus FDA site. The three spine, the posterior based artificial disc. I had people who tried to enroll at my place that were from 3 states away.
That's exactly right. Randy, I don't know if this is something you can comment on. Any thoughts about future indication expansion into deformity specifically for this, where it may have a more direct role as well?
Absolutely. I think your case coming up, we can discuss that. But Ed, I'm just going to give you a counter. So what this guy may be happy for now 2 years, but what happens in 3 to 5 years when he's back? Now you've got to extend this.
You're 100% right. It's the ongoing challenge. That's my response to that. It's the ongoing challenge.
Yeah, we just don't know. Would this, would an osteotomy give him 5-10 years of relief, or only 2 years? But we know it's going to happen with this, right? So, Michael, you want to do this one quick?
Yeah. I think to your point, what about the other end of the spectrum, right? What about a deformity case? Here's a 77-year-old woman, kind of frail. She's got really bad back pain, sagittal plane imbalance, pretty severe sagittal plane imbalance, proximal lower extremity pain. I'm not sure if I have the MRI up there, but she's got severe foraminal stenosis at that adjacent segment, but no severe central stenosis. So it seems to be, with her proximal leg pain, seems to be vertical foraminal stenosis, or at least degenerative foraminal stenosis from that next proximal segment above her old fusion. You can see what I did there. But instead of this, would a VBO with sagittal correction be suitable for this kind of case? Because certainly a one-level procedure would be more amenable to patients, less morbid. A lot of benefits to that if that works. So I kind of wanted to present this one too as two ends of the spectrum in terms of cases that we might think about as we're trying to think about how we might want to use this procedure. This would kind of be the other end of the spectrum, but technically you might be able to fix this with one level with a big osteotomy that solves her radiculopathy and also pulls her back into better sagittal alignment.
Michael, if you were to try something, I'd definitely fill this in with montage.
Yeah. I agree entirely.
Yeah. Great cases. Thanks.
I'll do this quickly.
Yeah.
So I do very little degenerative paraminal stenosis surgery directly. I do some in the setting of idiopathic type curves. So my patient population tends to be this patient here, adolescents, young adults, and middle-aged adults. And this is a patient 34 years old or 33, progressive, very painful, moderate 44-degree lumbar curve with a lot of rotation and back pain, very flexible. Perhaps this is a VBO at the apex and then tether above and below in the future. Her discs are relatively healthy, and these are some of the concepts we could consider, either an inner body, which is what I did, and tether across it, or in the future, 1 or 2 level or even 3 VBO. So what we did here is inner body apical fusion with XLIF approach. And then I don't have the foundation cage just yet, but when I do, I'll use that. And then we just tether it across it. This is something that Per Trobisch in Germany has been doing the last couple of years and has had some very satisfactory results. And this is about as much as we can correct these in some cases. If you put bilateral metal, metallic rods and posterior fusion, it's going to be a little straighter. But this is a home run for this patient. So I have a lot of tethers in this group with apical fusion now, and they restore their alignment, their deformity correction is excellent, and their pain relief is quite good, because the pain in these patients, usually, especially at this age, is convex muscle pain fatigue. And when you straighten them out, it relaxes and they feel better, so their pain goes away. Their deformity improves, and I think a 1-level apical fusion, even if the tether breaks in time, at least part of the correction will hold. And they don't break everywhere all at once. So the tether will break. Here we have only a single screw, so it'll probably break there, but you'll only have a moderate deformity. So I think as improvements in tethers come about, maybe VBO is an answer for this particular patient in the future. And that's the way I'm thinking in my practice.
Baron, do you think like the osteotomy, like if we cut it and say we put one set of screws across on just one side, or I don't know, do you think it'll still be mobile if we were doing instrumented correction with the VBO? Would it work, you think?
I think it would. I mean, I think you'd almost overcorrect it, on the concave side, you open it up more, do the VBO. You're saying with the tether across it or without tether?
I have a terrible case that I don't really want to deal with, but somebody sent me like really flat long segment fusion. It's had a bunch of surgery, nothing anteriorly, but needs a realignment, basically needs a VCR. But could you do multi-segment cuts and, through the bodies, and then, cut the fusion mass in the back, and you're not doing a VCR, and maybe you can get multi-segment corrections. I don't know. I mean, that's clearly not what this discussion is.
Harmonious multi-segment correction. Maybe it's safer than a VCR.
Yeah.
I agree. I think there's something to be said for multi-level harmonious corrections and diminishing morbidity of a more advanced 3-column osteotomy. I think it's something to consider for sure. We do some flatbacks with multi-level A-lifts, and maybe there are some posterior approaches that the company's developing that would allow harmonious multi-segment intervertebral body correction. So what you're thinking about, Sherby, is, I think, a great idea and something maybe worth exploring.
Baron, I recently had to debate somebody at a resident conference that they were claiming that young adult idiopathic scoliosis, just like this case you're presenting, is never progressive and is never painful.
Yeah. I see him every day in my practice. So does Randy. This lady she's a highly motivated tech engineer in San Francisco. Pain getting worse and worse, function diminishing, doesn't like her deformity. And they're there. There's some that are more, milder curves that aren't progressive, not painful. But these patients, they show up at your doorstep. And I think fusing her at age 33 throughout here and living only 2 discs below is going to end up leading to a full fusion 20 or 30 years down the line down to the sacrum with pelvic fixation. So as Billy said, I forget the term he used, but it's managing the spine. We're keeping her options open.
Yeah.
But it just
Fractional or fractionating it. I guess here's my other question, and this is a product question. Do you think you could monkey a way to make the tether screws go through the VBO?
I think that's what we're going to do. That's what we're
They
going
go through the plate, Billy.
That's what I'm saying.
Yeah, they already do.
Yeah. We'll do that, Billy. So anyway, Randy, I think we've reached our time. And Ed, do you want to say a good night, or should I just thank you?
No, I think this was great. Thank you, Baron and Ed, for moderating this and for everyone's participation. You guys were great. Excellent discussion.
Look forward to working with all of you guys going forward to figuring this out.
So so thanks everybody. Thanks for those of you who put cases together, and it was just great.